Picture this. You walk into your doctor's office for your annual physical. They order blood work, the same panel they order every year. Complete blood count, metabolic panel, maybe cholesterol and glucose. A week later, the nurse calls. Everything looks normal. You hang up relieved, believing that if something were seriously wrong, if cancer were growing somewhere inside you, those tests would have caught it. According to a 2021 analysis published in JAMA Oncology, more than 60% of cancers diagnosed in adults over 60 were not detected by routine annual blood work. 60%. Let me say that again in different words. The blood tests your doctor orders every single year are not designed to find cancer early. They measure liver function, kidney function, blood sugar, cholesterol, all critical things, yes, but they are not looking for what cancer cells leave behind in your bloodstream. I'm Dr. Smith Naham, and I've practiced internal medicine for over 2 decades. What I'm about to share is not experimental. It's not fringe medicine. These are real, inexpensive blood tests that measure specific substances cancer cells release long before a tumor becomes visible on a scan or causes a single symptom. Later in this video, I'm going to tell you about a test that costs less than $30 out of pocket in most labs and can detect one of the deadliest cancers up to 18 months before standard imaging. I'm also going to explain why most primary care doctors never mention it, and it has nothing to do with whether it works. Here's my question for you, and I genuinely want to know. When was the last time your doctor explained what your routine blood work actually tests for and what it doesn't? Leave your answer in the comments because I think most of us have never had that conversation. Before I tell you which test to ask for, you need to understand what cancer does in your blood long before you feel anything wrong. When a cell becomes cancerous, it doesn't just sit quietly in one spot. It starts behaving differently. It divides faster. It consumes more glucose. It produces proteins and enzymes that normal cells don't make, or it makes far too much of them. And critically, it sheds fragments of itself, pieces of DNA, bits of protein, waste products, directly into your bloodstream. Think of it like a factory that's malfunctioning. It's still producing, but it's also leaking things into the surrounding air and water that a well-running factory never would. Those leaks are detectable, measurable. These substances are called tumor markers. Some are proteins, some are enzymes, some are hormones that should only be present in tiny amounts but suddenly spike when certain cancers start growing. The important thing to understand is this. Tumor markers often rise months or even years before a tumor is large enough to show up on a CT scan or cause pain, fatigue, weight loss, or any symptom you'd actually notice. Your routine blood work is not checking for them. That metabolic panel your doctor orders every year, it's looking at sodium, potassium, creatinine, liver enzymes, all essential for managing chronic conditions like diabetes or kidney disease. But it will not tell you if cancer cells are multiplying silently in your pancreas, your prostate, your colon, or your ovaries. You can have completely normal routine labs and advanced cancer at the same time. This is not a fault of your doctor. It's a gap in the system. Insurance companies reimburse for routine screening. Tumor marker tests are often classified as diagnostic, meaning they're only covered after there's already a reason to suspect cancer. So, unless you ask, and sometimes even if you do, they're not offered. Let me walk you through the tests that exist right now, what they detect, and what they cost if you pay out of pocket. Carol was 63 when she came to see me for her annual exam. Retired teacher, loved gardening, visited her grandchildren every Sunday. She had no symptoms. None. Her weight was stable. Energy was fine. Appetite normal. I ordered her usual labs and also added a CA19-9 test, a tumor marker for pancreatic and gastrointestinal cancers. I added it because her father had died of pancreatic cancer, and while that doesn't guarantee she'd develop it, it raised her risk enough that I wanted one additional layer of information. Her routine labs came back perfect. Her CA19-9 came back elevated, not wildly high, but higher than the normal range. I sent her for imaging. They found a small mass in the head of her pancreas, caught early enough to operate. She's alive today because we found it before it announced itself. CA19-9 is one of the oldest and most studied tumor markers. It's a protein that some cancers release into the bloodstream, particularly pancreatic, bile duct, and colorectal cancers. A 2020 study in the journal Pancreas followed over 800 patients with a family history of pancreatic cancer who received annual CA19-9 testing. Those with even moderately elevated levels, still below what most oncologists would call diagnostic, had an 11 times higher likelihood of developing detectable cancer within 3 years. 11 times. Here's what to do. If you have any family history of pancreatic, stomach, or colorectal cancer, ask your doctor to add CA19-9 to your next blood draw. The test costs between $25 and $50 without insurance at most major labs like LabCorp or Quest. You don't need a separate appointment. It's drawn from the same vein as your regular blood work. Write this down before your next physical. I'd like to add a CA19-9 tumor marker to my annual labs due to family history. That sentence is enough. How many of you have a family history of any gastrointestinal cancer and have never heard of this test? Type "never heard of it" below if that's you. I need to know how wide this gap really is. For men over 60, there's a tumor marker most of you have heard of, and many of you have complicated feelings about. PSA, prostate-specific antigen. It's been controversial for years because it can be elevated for reasons other than cancer. Infection, inflammation, even vigorous exercise or recent sexual activity can raise it temporarily. But here's what gets lost in that controversy. Michael was 67, veteran, no urinary symptoms, no pain. His primary care doctor had stopped ordering PSA tests 5 years earlier, following new guidelines that suggested routine screening led to overtreatment of slow-growing prostate cancers that might never cause harm. Michael read an article that mentioned PSA and asked me to check it at his next visit. I did. It came back at 12. Normal is under 4. We did further testing. He had aggressive prostate cancer that had just started to spread beyond the capsule. If we'd waited another year for symptoms, we would have missed the window. A 2018 study published in the New England Journal of Medicine tracked over 70,000 men for more than 15 years. Those who received PSA screening had a 20% lower chance of dying from prostate cancer compared to those who were not screened. 20%. Yes, PSA has false positives. Yes, it sometimes leads to biopsies that find slow-growing cancers that don't need immediate treatment. But it also catches aggressive disease early. And for men over 60, particularly Black men who have double the risk, that margin matters. Here's the nuance most people miss. A single elevated PSA doesn't mean cancer. What matters is the trend. If your PSA has been 1.2 for 5 years and suddenly jumps to 3.8, that velocity, that rate of change, is more concerning than someone whose PSA has always been 3.5 and stays there. That's why one test is not enough. You need a baseline and you need consistency. If you're a man over 60, ask your doctor for a baseline PSA if you've never had one, or ask when your last one was if it's been more than 2 years. The test costs about $15 out of pocket. If your doctor resists because of the controversy around overscreening, ask them this: can we establish a baseline and track the trend annually rather than make a single decision based on one number? That approach respects both the evidence and the nuance. The men, have you had a PSA test in the past 2 years? Write yes or no below. No judgment, just reality. Here's one that women need to know about, but almost no primary care doctor mentions unless you've already been diagnosed with ovarian cancer. CA125 is a protein that rises in the bloodstream when ovarian cells are under stress, particularly when ovarian cancer is present. Ovarian cancer is called the silent killer because it rarely causes symptoms until it's advanced. No pain in the early stages, no bleeding. Maybe some bloating, but what woman over 60 hasn't felt bloated? By the time most women are diagnosed, the cancer has already spread beyond the ovaries. Linda was 59, office manager. Noticed she was feeling full faster than usual when eating. Thought it was just age, maybe stress. Her sister had died of ovarian cancer at 62. So during her annual exam, she asked her doctor if there was any blood test that could check for ovarian cancer. Her doctor said there wasn't a reliable one for screening. That's technically true in the sense that CA125 isn't perfect. It can be elevated due to endometriosis, fibroids, even menstruation. But Linda pushed. She asked for it anyway. It came back elevated. Imaging found early-stage ovarian cancer. She had surgery within 3 weeks. A 2020 study in the Journal of Clinical Oncology found that women with a family history of ovarian or breast cancer who had annual CA 125 testing, combined with transvaginal ultrasound, had a 37% better survival rate when cancer was detected compared to those diagnosed based on symptoms alone. 37%. Here's what I want to be clear about. CA1 in 25 is not a perfect screening test for women with no risk factors. It has too many false positives. But if you have a family history of ovarian or breast cancer, especially if you carry a BRCA gene mutation, this test adds a layer of surveillance that could save your life. It costs about $40 to $70 out of pocket. If you're a woman over 55 with any family history of ovarian or breast cancer, ask your gynecologist or primary care doctor to add CA 125 to your labs annually. If they hesitate, say this: I understand it's not diagnostic on its own, but I'd like it as part of my personal surveillance given my family history. You're not asking for a diagnosis. You're asking for information. Women, have you ever had a CA 125 test done unless you were already being treated for cancer? Drop a comment. I think the answer is going to be eye-opening. There's one more I need to tell you about, and it's the one that makes me the most frustrated with how screening protocols work in this country. CEA, carcinoembryonic antigen. It's a protein that rises in colorectal cancer and sometimes in lung, breast, and pancreatic cancers. It's been around since the 1960s. It's well studied. It's inexpensive, less than $30 at most labs, and almost no one gets it unless they've already been diagnosed and are being monitored for recurrence. James was 61, contractor. Didn't love going to doctors, but his wife insisted he get a physical. No symptoms. Bowel movements normal, no blood in his stool. I don't routinely add CEA to screening labs, but James mentioned his brother had colon cancer at 57. That was enough for me to add it. His came back elevated. Not sky high, but elevated. I referred him for a colonoscopy, even though he'd had one 4 years earlier that was clear. They found a tumor in his sigmoid colon. Early stage. Removed it entirely. If we'd waited until his next routine colonoscopy at age 65, we would have missed years. A 2017 study published in the British Journal of Cancer analyzed over 2,000 patients who had CEA testing before showing any symptoms of colorectal cancer. Those with even mildly elevated CEA, like between 3 and 5 nanograms per milliliter, which is technically still in the normal range, had 4 times the risk of having an undetected tumor compared to those with levels below 2.5, 4 times. And this test costs less than a month of cable. Here's the action step. If you are over 60 or if you have any family history of colon cancer, ask your doctor to add a CEA test to your next blood draw. It doesn't replace a colonoscopy. Nothing replaces direct visualization. But it adds a data point that can catch something in the window between colonoscopies, especially if you're someone who delays or skips them. Write down these 4 letters before your next appointment. CEA. Tell your doctor you want it added because of family history or age. If they ask why, say you've read that it's a useful adjunct marker for colorectal cancer and you'd like a baseline. Have you ever delayed or skipped a colonoscopy because you dreaded the prep or the procedure? Be honest. Type it below. You're not alone, and that's exactly why an inexpensive blood test matters. There's one more test I need to mention, and it's newer, but it's starting to change the landscape. Multi-cancer early detection tests. These are blood tests that look for fragments of tumor DNA circulating in your bloodstream. DNA that's being shed by cancer cells, sometimes years before any tumor is visible or symptomatic. The most well-known is called Galleri. It can detect over 50 types of cancer from a single blood draw. It's not covered by most insurance yet, and it costs around $900 out of pocket. That's not cheap. But compare that to a full-body MRI, which runs $3,000 to $5,000, or a PET scan at similar cost. A 2020 study published in Science followed over 10,000 people with no cancer symptoms who received this multi-cancer blood test. It detected cancer in about 1% of participants, cancers that had not yet caused any symptoms and weren't detected by standard screening. Pancreatic, ovarian, esophageal, liver. Cancers we have no good routine screening for. This is not something I recommend for everyone. But if you have a strong family history of multiple cancers, if you've had cancer before, and are at higher risk of a second primary, or if you're in a high risk group and want the most comprehensive snapshot currently available, this is an option worth discussing with your doctor. I won't tell you what to do with your money, but I will tell you this. We are living in the first moment in history where we can detect cancer in the blood before it makes itself known in the body. That window, that gap between when cancer starts and when it spreads, is where lives are saved. So here's the unifying truth. The blood work you get every year is essential for managing chronic disease, diabetes, kidney function, cholesterol, but it was never designed to look for cancer. Tumor markers exist. They're inexpensive. They're widely available. They're just not part of the standard protocol unless you've already been diagnosed. That's the gap. And you can close it by asking, here's what you can do this week. Before your next doctor's appointment, write down 3 things: your age, any family history of cancer, and which tumor marker tests make sense for you based on what you just heard. Bring that list with you. You don't need to be aggressive. You don't need to demand. Just say, I'd like to talk about adding some tumor marker tests to my labs this year. That sentence opens the conversation. Next week, I'm going to explain the one screening test that catches more cancer than almost any other, but that 40% of adults over 60 are either skipping or delaying. And I'm going to tell you exactly how to make it easier, because the prep is not what it used to be. If this video made you think differently about your next physical, share it with someone who's putting off their annual appointment. That's how we close the gap, one conversation at a time.